Good afternoon. My name is Carrie Kroll. I'm the Vice President of Advocacy, Quality, and Public Health for the Texas Hospital Association, and I'm excited to be here today to present our speakers for this afternoon panel related to the 2019 legislative session. They're going to focus on the key outcomes. So, to my right, we have Dr. Manda Hall. She is an Associate Commissioner for Community Health Improvement and also serves as the Title V Maternal and Child Health Medical Director at the Texas Department of State Health Services. Prior to these positions, Dr. Hall served as the Interim Associate Commissioner for Family and Community Health Services and as the Title V Children's with Special Health Care Needs Director. She has also experience in private practice, worked as a state agency medical consultant and at disability determination services in Austin. Dr. Hall graduated with her Bachelor of Science degree in biology from Lamar University and her medical degree from Texas A&M in biology from, I'm just going all over the place. I'm going to assign you a bunch of different degrees. Texas A&M University Health Science Center College of Medicine. She completed her residency and fellowship at the University of Alabama at Birmingham. Dr. Hall is board certified in internal medicine, pediatrics, and allergy and immunology. She is a faculty member of the DSHS Preventative Medicine and Public Health Residency Program and serves as a mentor in the University of Texas Health Careers and Mentorship Program. We also have with us this afternoon Stephanie Stevens. She is the TCHMB HHSC representative and the Deputy State Medicaid Director. My apologies. Stephanie Stevens serves as the Medicaid Director at HHSC and provides strategic direction and oversight of policy and quality for Texas Medicaid and the Children's Health Insurance Program. Stephanie has nearly 15 years of experience in Texas Health and Human Services policy, finance, and operations. She first joined HHSC in 2008 as Medicaid and CHIP policy analyst and advanced through the Medicaid CHIP organization and HHSC. Her prior leadership roles have included Senior Policy Advisor and Policy Director of HHSC's Office of Social Services, where she directed strategy, analysis, development, and implementation of eligibility policy for Texas social service programs. Before joining HHSC, she served as a Health and Human Services Budget Analyst at the Texas Legislative Budget Board for over 4 years. She is committed to excellence and innovation in administrative health care and social services to Texas. So please join me in welcoming both these ladies.
Well, thank you, Carrie. It's a pleasure to be here this afternoon and to be here with Stephanie. Stephanie and I work a lot together. Our programs have the ability to really kind of have opportunities for collaboration and coordination to really look at opportunities to improve maternal and child health. So we are happy to be here, good, it's working, to talk about some of these key legislative outcomes. I'm going to kick us off by talking specifically around some of the bills that passed at DSHS, focusing on those impacting maternal mortality and morbidity and some that impacted newborn screening. And then I'm going to turn it over to Stephanie to talk about bills related to HHSC. And you're going to find that we're going to be talking about some of the same bills because we had some bills passed during this last legislative session that really impacted across our entire system, but really also opened up the opportunity for us to continue to further working together. So the first bill I wanted to talk about this afternoon, was Senate Bill 436. It was passed. It was by Senator Jane Nelson. And this bill actually directs the Department of State Health Services to implement a statewide initiative to improve maternal care for women with opioid use disorder. And we continue to make great strides with this effort. We're currently working through a pilot project to learn about strategies, resources, opportunities, and needs for implementation of the Obstetric Care for Women with Opioid Use Disorder bundle by the Alliance for Innovation on Maternal Health, or AIM. As part of this Texas AIM initiative, we have 10 champion hospitals that are independently implementing components of this bundle, and they're now sharing their experiences to date through regular pilot working group calls. This pilot part is going to wrap up in March of this year. And we are then going to work with these partners through the spring to really synthesize all of this information and finalize the bundle and strategy for statewide implementation. The next bill that I wanted to talk about was Senate Bill 748 by Senator Lois Kolkhorst. And this bill is aimed at combating maternal mortality and morbidity and also at enhancing newborn screening. So this directs our task force, which is now called the Maternal Mortality and Morbidity Review Committee, to collaborate with and offer consultation to the Texas Health and Human Services Commission on topics related to maternal and women's health. This bill also requires DSHS to launch a pilot program for women at high risk for complications during and after pregnancy. This bill also directed our agency to apply for the 5-year CDC grant called the Enhancing Reviews and Surveillance to Eliminate Maternal Mortality, or the ERASE-MM grant. I am happy to tell y'all that we did apply for this grant and we were awarded this grant by the CDC, and we're currently working to implement this. This grant is going to allow us to add additional infrastructure around the work of our Maternal Mortality Review Committee. This committee, I believe we've mentioned earlier today, but this is the committee of experts that meets to review cases of maternal deaths and then make recommendations to our legislature on opportunities to improve maternal health outcomes. Some of those key recommendations have been around maternal health and safety, around care coordination for women, around awareness as it relates to maternal health outcomes. And you're going to see some of that as we continue to talk about some of the bills and funding that was DSHS received during this session. In addition, there were components of this bill related to newborn screening. This bill requires fees to cover the cost to conduct federally recommended newborn screening and creates a special preservation account, and in doing so forges a path to sustain funding for this purpose. As a result of this bill and funding from the legislature, DSHS is working towards implementing the screen for spinal muscular atrophy, or SMA. Lastly, Senate Bill 748 also directs physicians or other birth attendants to collect a blood sample at the time of delivery and submit for congenital syphilis testing. And while this does not direct DSHS to any action or change our reporting, it does have us sharing information to stakeholders and making necessary updates to our educational materials on this topic. Next is Senate Bill 749, also by Senator Lois Kolkhorst, which is also aimed at combating maternal mortality and morbidity, and it relates to the implementation of neonatal and maternal levels of care at hospitals throughout the state. This particular program is implemented through DSHS, but this is through a different division, our Consumer Protection Division, and I know some of the members of that team are actually here at the conference. These levels of care designation are to ensure that newborns and pregnant women receive risk-appropriate care. And this bill requires DSHS, in consultation with the Perinatal Advisory Council, to conduct a strategic review of the implementation of the new rules for neonatal and maternal levels of care. Based on this review, DSHS must then make recommendations for how these rules should be modified to improve the process and methodology of assigning levels of care designation. And the bill also clarifies that hospitals are not required to have a maternal level of care designation in order to be reimbursed for maternal services through the Medicaid program until September 1st of 2021. And then finally, the bill outlines a process for hospitals to appeal their designation, as well as how to waive certain requirements for a designation. In December of 2019, DSHS submitted an initial strategic review report on the neonatal levels of care. There will also be a supplement to the neonatal focus report to be submitted by the end of 2020. And this will incorporate feedback from the PAC about the current levels of care rules and changes required by this bill. And then based on these anticipated recommendations, DSHS is then going to initiate a public rulemaking process to implement the changes related to this and address other issues identified during the strategic review process. And then they will use the same process to submit a strategic review of the maternal levels of care by December 31st of 2020. The next bill that I wanted to touch base on is Senate Bill 750, also by Senator Kolkhorst, and this directed the rename of our task force to the Maternal Mortality and Morbidity Review Committee. It also added a requirement that hospitals and other providers submit records to DSHS within 30 days for case reviews by the committee. For those that may not be aware, part of being able to review the cases, our team has to reach out to different hospitals, different providers to get medical records, and they go through a very extensive process to synthesize them into a kind of a case report that can be used by the review committee. But one of the barriers that we have continued to see has been the length of time that it takes for us to actually receive records from providers. So this really was geared towards trying to eliminate some of those barriers that our review committee actually faces in reviewing these cases. And then finally, this bill allowed DSHS to release certain information requested by the CDC, and what this allowed us to do was to be able to meet the requirements for the Erase MM grant. As we headed into our last legislative session, DSHS had submitted an exceptional item, and this exceptional item was geared towards combating maternal mortality and morbidity. And fortunately, we were actually appropriated funds to implement 3 initiatives related to maternal health and safety. We received a total of $7 million over the biennium and 8 FTEs. So the first part of this is we are going to sustain and implement additional AIM bundles. So I know that you've heard us talk about moving into the next bundle, which is severe hypertension in pregnancy, as well as going statewide with the bundle related to opioid use disorder. And these, the funding and additional staff are going to allow us to be able to do that. We also received funds to launch a high-risk maternal care coordination pilot. This is going to include the development of a risk assessment tool to identify pregnant women who are at higher risk for poor pregnancy, birth, and postpartum outcomes, as well as develop educational materials for community health workers who can offer education and support to women in their communities. And then finally, funds were appropriated to design and implement a public awareness campaign here in Texas. Let me go back. Okay. Sorry. I skipped the newborn screening piece. I can't see the bottom of the slide. In addition, House Bill 1 awarded funds to DSHS for enhancing newborn screening. In August, funding from this allowed DSHS State Laboratory to begin testing all newborns for X-linked adrenoleukodystrophy, or XALD, making Texas the 16th state to add XALD to its screening panel. XALD is a rare genetic disorder characterized by damage to the nervous system and the adrenal glands. XALD affects about 1 in 17,000 people worldwide, and we expect adding this screening will help identify 10 to 14 cases a year in Texas and allow us to be able to help connect those children and their families to treatment before they show any symptoms. To allow for funds to accrue in the special newborn screening preservation account, the legislative also provided DSHS with startup funds to set up new screens upon LBB approval, and we're currently working with the LBB on that, and that will allow us to begin implementation of screening for SMA. And once that is approved, it will take about 18 months to begin screening. SMA affects about 1 in 10,000 infants worldwide, and we expect adding this screening will help identify approximately 20 cases per year here in Texas. We know that early diagnosis is key to preventing the most serious harmful effects, and newborn screening can be a life changer for babies with rare disorders, and we are so pleased to broaden our screening panel. Early intervention makes a dramatic difference in quality of life, and the work of our DSHS State Laboratory, together with our newborn screening care coordination program, helps improve the lives of Texas babies. So now I'm going to turn it over to Stephanie.
Thank you, Dr. Hall. So which button?
Down.
Okay. So for HHSC, the maternal health legislation really focused on a couple key areas, and that is enhancing the benefits and services for Medicaid and Healthy Texas Women, and also ensuring continuity of care. But, excuse me, I have a cough, so I'm going to do my best. But between those two services, and so I'm going to mainly focus on the Medicaid piece of that continuity of care. And so before I talk about enhancing Medicaid services for pregnant women, I just wanted to talk about what does the benefit package look like today. So we do provide a comprehensive array of services for pregnant women in Medicaid, which includes prenatal care, labor and delivery, postpartum care. We also provide service management for high-risk pregnant women. And then we have a number of provisions to ensure care continuity. So if a pregnant woman is currently being served by someone who's out of network, they can continue to see that provider for some period of time as they transition into the managed care organization. So that's sort of the foundation of what exists today in Medicaid. And then Senate Bill 748 required HHSC to implement 2 pilot programs. One is a pregnancy medical home, and the second is maternal teleservices. And both bills specify the size of the pilot areas and also the number. So that is specified in the bill, what geographic areas we need to cover in this pilot. For pregnancy medical home, the goal is really to provide coordinated, evidence-based maternity care management, and we will be building off a prior pilot that we've had in the Medicaid program for pregnancy medical home. The bill specifies a number of components that must be part of that pregnancy medical home, which includes a maternity management team, a risk assessment, and also a pregnancy care plan. And so what we're gonna be doing is surveying providers and our managed care organizations to identify who is interested in this, who today has the ability to provide these services, and then we'll use the response to our survey to sort of design the pilot, and it will be delivered through what's called our STAR managed care model, which is the program that pregnant women receive services through. And so we're in the process of re-procuring our STAR managed care model, so the actual pilot won't begin until we have that new procurement completed. Senate Bill 748 also requires us to develop a pilot program to deliver maternal care via teleservices to low-risk pregnant women. So we've started to do research on what services today are pregnant women receiving via teleservices in Medicaid. And we've also engaged our external quality review organization to do research on what's happening in other states, what generally does the research say about the cost and benefits of teleservices for this population. And then we're gonna be taking that research and analysis that we've done to the March meeting of the Maternal Mortality Review Committee. Did I say that right? I missed it. I think I missed an M. So the review committee, we'll be taking it to the March Review Committee to get their feedback and input and to sort of shape where we go with the pilot moving forward. In addition to Senate Bill 748, 750 had a number of requirements that address women's health services at HHSC, and I'll walk through again those provisions that are impacting the Medicaid program. So like DSHS, we have some good news. Senate Bill 750 directed us to apply for federal funding to implement a model of care for women with opioid use disorder. And we're happy to announce that we are among 10 states that was awarded that funding. And thank you. Yes, we like to celebrate this win. And we're very excited about it, and we appreciate our partners. This is a partnership with Harris Health, Ben Taub, Baylor College of Medicine, a substance use provider, Santa Maria Hostel in Houston. And so this is the first year of the pilot, and we're kind of in a pre-implementation phase. But by 2021, we'll be moving towards implementing a multidisciplinary clinic for these women. So we're very excited about that. Senate Bill 750, as I mentioned, also directed us to enhance the prenatal care services in Medicaid and also to ensure that we have that continuity of care between Medicaid for pregnant women and Healthy Texas Women. So as I mentioned, we have a comprehensive benefit package today for pregnant women. The bill doesn't define what enhanced prenatal services are. So we started with doing some research on what's the lay of the land in other states, what does research say should be part of a prenatal package. And we're also surveying our health plans to see on a number of different areas. So what screening tools are they using? What care coordination are they providing? How are they identifying women for service management? So we're surveying them as well to see sort of what are the best practices amongst the managed care organizations. And then we plan to kind of synthesize that research and make it available by the spring of this year, and then determine sort of the next steps for what prenatal care services may be an option to add. And for the continuity of care piece, one of the things we're looking at is identifying for our managed care organizations and their members who are the providers that are participating in Healthy Texas Women, so we can see what opportunities there are to for women to know who may be a future provider that they can use, and to sort of try to ensure continuity of care to the extent possible between those two programs. Also in Senate Bill 750, we received direction to assess providing Healthy Texas Women's services through managed care, and if feasible and cost effective. We had done some work on this through session, looking at what might it look like to provide those services through managed care, but we really want to get stakeholder input to make sure that our analysis is complete and to identify any factors that we might not be considering. And so there will be an effort where we're requesting your information from stakeholders on their different factors we should consider in this analysis. And so that should be coming out soon, again, this spring. We also got direction to implement a postpartum depression treatment network, and this one we will be working on to include in our postpartum depression strategic plan, which is scheduled to be published in September 2020. And again, there will be opportunity for stakeholder engagement through that process. For some reason, I just saw myself on that screen. That was a little disturbing. Sorry. Why am I there? Sorry. So the last requirement is that we develop statewide initiatives to improve the quality of maternal care services and outcomes. So there's a lot of things happening in managed care and across the state around quality for maternal services. And this is really an opportunity for us to look at the things that are occurring across the state and determine where there's an opportunity to implement some of those things statewide. So one of the things we're looking at is, and sort of to align with the work that DSHS has done around the AIM bundles, we're looking at potentially implementing some AIM outcome measures, and there will be an opportunity for stakeholders to provide us feedback on that, but it would be a phased-in implementation. So generally when we implement quality measures, we start with measuring them, making them public, and then over time we can incorporate them into some of our alternative payment models or pay for performance with Medicare managed care organizations, but it would be a phased-in implementation over time. We're also working with DSHS to pull together a work group. So we have a value-based payment and quality improvement advisory committee that advises us on what it sounds like, value-based payments. But and so we want to pull in maternal health experts and bring them together with members of that committee to really look at what measures might be good candidates for any statewide initiatives. And so that will be happening soon. Mm-hmm. And then we have again surveyed the plans to kind of understand what their best practices are for ensuring timely access to prenatal and postpartum care. And we are participating in a collaborative around social determinants of health. And so we see that as an opportunity to, again, understand what the lay of the land is today and then identify any opportunities for statewide initiatives to address social determinants of health for this population as we move forward. So that's the summary of what's happening at HHSC related to maternal health legislation. And I can turn it over to Ms. Kroll.
Excellent. I think I need to go up here. Well, that was well-timed, ladies. We have 5 minutes, I think, just perfectly for a question, or two, depending on what kind of question we get. So I'll ask those of you in the audience to join us at one of the microphones if you have a question you'd like to ask. Got one over here. Yes, ma'am.
It's kind of twofold. when might those enhancements be identified, and might doula coverage be one of the enhancements?
That's a good question. So again, our timeline for the enhanced services is really, we're trying to pull the work together this spring to identify what the options might be moving forward. Of course, that's not when they would necessarily be implemented, but really pulling together the work we've done and developing some options. I have not heard doula as a specific service that's been mentioned. That's come up in our research, but I do have team members here, and so I'm sure they're hearing you say that, and we will consider that as we move forward. Thank you.
I'll say it again, doula. Yeah. Some of the states on the East Coast do it very well, and they have better outcomes specific in reduced rates of maternal mortality.
Okay. Thank you.
Thank you.
Yes,
I
ma'am.
have a question in regarding to the implementation. You stated that, if I heard correctly, that you're looking to the MCOs and how they're assessing maternal mortality, how they're implementing programs in maternal mortality. My question is, MCOs during the request for proposal time, are they expected to submit measures regarding maternal mortality within those packages?
So there's a number of different things that I want to make sure I understand your question, because there's a number of different, so Medicaid, and you may all know this, but Medicaid is delivered primarily through managed care in the state of Texas. You know, we're at like a 95% managed care enrollment. So which specific part were you asking about? Because there's a number of things that are being considered that would happen in managed care. Can you clarify what specific?
So example, if managed care is going to receive Medicaid dollars to combat maternal mortality, and a part of maternal mortality is systemic racism, chronic oppression, social determinants of health, having access to certain things, are you requiring those MCOs to submit plans in request for proposal to combat those things?
That's helpful. Thank you for that clarification. So a number of things. The plans today do things in the area of social determinants of health. They also have what's called performance improvement projects that they have to do. They have to do 2 per every 2 years, and they have done things on disparities in the maternal health space. And so what the focus of this is today there's a lot of flexibility in the managed care model, so you'll see plans doing different things for social determinants of health and to address health disparities. And so part of this effort is to pull together the information on what they're doing and seeing, okay, where were plans successful with certain interventions, and then is there an opportunity to do something statewide. So they are doing things in those spaces today, but it can vary, and so we want to look at, is there an opportunity, and to what extent is there an opportunity for any alignment?
Thank you.
Sure.
Let's see. Please, go ahead.
Okay, thanks. Emily Adhikari, I'm at Parkland Hospital. I may have missed this, so just clarify for me. One of the gaps that we see frequently in our patient population is that women, particularly those women who aren't traditional Medicaid patients but are CHIP perinate covered, and we need outside specialty services during their pregnancy, for ambulatory referrals and things. We can't get them into any other clinics because they don't have the right funding. And so is there something is there a conversation about that, about how to cover those services? For example, I need to refer my patient to a rheumatologist, or I need to refer my patient for penicillin allergy testing. I can't do that right now.
And you're talking about specifically for CHIP perinatal?
Yes,
Yeah.
all of the above, but in particular those who are not traditionally funded.
Yeah, I mean, I think there's some special considerations around CHIP perinatal just because of the benefit package and the way who it's targeted at.
Because it's not, directly related to the pregnancy.
Right.
Uh-huh.
And so that's not part of the discussion in terms of that changing, that the benefit still needs to be related to the pregnancy as the program to meet the program requirements. So that part is not part of the work we're doing at this point.
I would argue that this entire conversation means that their medical care and their health is related to their pregnancy.
Yeah, I understand. I understand.
Absolutely. I think we have a successful model in our state where both the commission, HHSC and DSHS are working together in tandem to try and figure out how to support these subpopulation, or these holes in coverage that might exist. And remember, everything is legislatively mandated, so we will be actively, those of us that are advocates in the room that can be out there doing that, will be actively advocating for additional services in the coming session, because it will be here before you know it. So for now, if you'll join me in thanking these two ladies for their time today. I appreciate it. Sorry. And we'll do a quick transition